Gino K, MD, MPH, Associate Professor of Clinical Medicine at USC Norris Comprehensive Cancer Center, shares pivotal updates on advancing melanoma and skin cancer therapies in our exclusive interview. Notable quotes from this interview. Quote, "So we really think that when it comes to survival, using immunotherapy first is the preferred option. Even patients who've had almost every other available melanoma therapy and not respond to those therapies, up to a third of those will respond to TL therapy or Lifileucel. There was a clear benefit with a hazard ratio of 0.31, clearly favoring the role of adjuvant PD-1. Why start with immunotherapy before targeted therapy for BRAF mutant melanoma?"
So starting in 2015, for patients who had advanced melanoma and BRAF V600 mutations, we really found that we had two different effective therapies. One being the combination of PD-1 and CTLA-4 for the immunotherapy approach, and then the other being BRAF and MEK targeted therapy as a more targeted therapy approach. And we saw that they were both very effective. Patients were living longer and they were having disease control. But there were definitely differences in the outcomes that we would see with these regimens. With immunotherapy, with Ipi-Nivo, for example, we would see that response rates were a little bit lower, probably somewhere in the 50 to 60% range, but the patients who responded would have long overall survival. And we know that patients treated on the original study, Checkmate 067, had 10-year survival rates that could be in the 40 to 50% range. So there were some long-term patients who would survive with that therapy and never need another line of therapy. With BRAF MEK, we saw higher response rates, somewhere in the 70 to 80% range. But the problem was that this did not seem to be as a durable therapy, meaning that within 1 to 2 years, a lot of patients who were responding would see those responses stop, and those patients would then progress. And knowing this, that became a big question. We've got two different drugs, or two different approaches that work well. Which one should you use first? And so the DREAMSeq study was designed to answer that question. If we do the immunotherapy first and then targeted therapy next, is that better, or is targeted therapy first followed by immunotherapy better? So this study randomized patients into two groups to get those two different sequences. This was in the era when both of these regimens were already approved, and it was purely just looking at the sequence. And the primary outcome from this study showed that at the 2-year mark, roughly 70% of patients were alive if they got immunotherapy first, compared to about 50% if they got targeted therapy first. And now we've got 5-year data to show what happens up to 3 years later for those same patients enrolled in this study. And again, we see that the overall survival continues to favor immunotherapy first. And in fact, the difference in the survival rates is even greater than before. So we really think that when it comes to survival, using immunotherapy first is the preferred option. If you look a little bit closer at this publication, you'll also see that the targeted therapy, when used later, still works just as well. But the immunotherapy doesn't seem to work as well, and we think part of that is due to the resistance mechanisms as well. So in our practice, we generally always offer patients immunotherapy first. The only exception there is some patients have very symptomatic disease. They're having almost like a visceral crisis, and some of these patients, or maybe they have brain mets and they're on steroids. So except in these kind of certain situations, we generally use immunotherapy first. If they're very symptomatic, maybe we'll give target therapy first, but then we try to get them back to immunotherapy sooner rather than later.
What long-term benefits does Lifileucel offer for advanced melanoma after other treatments fail?
So Lifileucel, also known as tumor-infiltrating lymphocyte therapy, or AMTAGV, is an adoptive cellular therapy. It's a one-time treatment that harnesses the power of the immune system, but in a very different way from immune checkpoint inhibitors. The process involves resecting a single metastatic tumor, isolating these specific cells known as tumor-infiltrating lymphocytes, these white blood cells, selecting the ones that have proven anti-tumor efficacy, and then growing billions of these cells in a laboratory. and then reinfusing these cells into the patient to ensure that we're giving them white blood cells which are specifically trying to attack the tumor. This is a one-time therapy, and we know that even patients who've had almost every other available melanoma therapy and not responded to those therapies, up to a third of those will respond to TIL therapy or Lifileucel. And recent updated data has really shown that even though this is a one-time treatment, 5 years later, some of these patients continue to have responses. They continue to do well. Many of them don't need any further treatment. And we know that over time, too, some patients who have stable disease initially can become responders, or some responders can have complete responses. So it's exciting times because this high-risk therapy is also high reward. We can see patients who we think will have long-term benefit when they haven't responded to any other therapy.
Why does PD-1 therapy after surgery help prevent high-risk skin cancer from returning?
So high-risk skin cancers, especially cutaneous SCC, these are patients who historically have sometimes had multiple recurrences. They've had upfront surgery, but they can have disease that recurs in their neck, in their lymph nodes, and they can have multiple rounds of surgery, they can have multiple rounds of radiation, even cytotoxic therapy like cisplatin, and still keep having recurrences. And in many practices that specialize in this disease, that's not uncommon at all. Now, for patients who have metastatic cutaneous SCC, we know that PD-1 therapy is effective. It can lead to really dramatic responses that improve both morbidity and mortality. And so this CPOST study looked at the use of PD-1 therapy in the adjuvant setting. And when we looked at disease-free survival, there was a clear benefit with a hazard ratio of 0.31, clearly favoring the role of adjuvant PD-1. So for patients who we specifically select, who we know they have a very high risk for recurrence, especially patients who've already recurred multiple times, this therapy can really change outcomes and hopefully prevent the disease from coming back again.